just stepped out.
Oh, yeah, Brooke,
Right back.
yeah, Brooke will be right back.
Oh, okay.
Here she comes.
All right, well, I'll go ahead and at least kick it off for, oh, wait. Oh, there's Brooke. Okay. All right, well, welcome to the Monday, April 10th, 2023 regular Board of Health meeting. The time is now 5:31. And our first item is public comments. So as a reminder, the Board of Health provides opportunity for the public to share their viewpoints and opinion on public health matters, and not at the practice of the board or agency staff to review, vet for accuracy or grounding and scientific evidence or provide responses to public comments. Opinions expressed by the public should not necessarily be interpreted as accurate if staff or the board does not challenge the perspective. So I believe we have 2 public comments tonight. Is that correct?
So we had one written comment that was submitted to the board, and then we had a request to speak. That was Ryan Scott, but I do
Okay.
not see him online. So I'll leave it to the subject of the board if and when he does log on. Oh,
All right.
Who was the other one? Steve?
Okay, should we start with the
Um,
written comment first?
Well, the written comment, it was submitted to the board.
Oh,
You
all
have
right.
it. Yeah,
Oh, it's just a written comment.
yes,
Okay.
sorry, just written.
So Ryan was the only one who had planned to speak?
Yes, and I do not see him online.
Okay. All right, well, we can come back to that if he does join.
Okay.
All right. So item 2 is the approval of the March 13th, 2023 regular meeting minutes. And I apologize, I was not at this meeting because I was on vacation.
I move to approve the March minutes, regular meeting minutes. I will second.
Motion in a second, all in favor?
Aye.
And then Ryan did just log on.
Okay. All right, well, we'll go back. Ryan, welcome. You have 3 minutes to make comment.
Thanks for circling back. Appreciate it. Just curious, I maybe missed the comment, but certainly advocating for you all allowing the public to attend your meeting in person. I think video chat doesn't do it. You guys have been trying to do that since September. So all I can say with encouragement is make it happen. Boulder City Council, Arts Commission, County Commissioners, every other group's made it happen except for you guys. So if you could, that would be appreciated. Back to COVID, I think we see the public health emergency winding down arbitrarily at a future date, which I think is comical in itself. So, you know, I certainly hope that there's been a little bit more expansion on your thoughts on that thread over time. I find it appalling that they're still being recommended, but you can see other countries are rolling back their recommendations, Switzerland being one of them. So good on them. They do not recommend the COVID vaccine anymore. We've seen the COVID shot looks like a nuclear bomb in someone's system, immune suppression, increased cancer rates, reactivation of latent viruses, now 35,000 deaths in bars, over 1.5 million adverse events. Again, no one in your group has ever acknowledged this, and you thrust your position on the community, which is why I continue to show up here. You made my life immeasurably harder for no reason. The community transmission levels, boy, I wish we had those back in 2021, earlier 2020, are another arbitrary threshold. So again, I think there's a lot of anger in the community. I think it's unfortunate you hide from the community. You disable all your comments everywhere. Public can't attend. It's only this short comment period. I find this to be relatively ineffective rather than chatting with you. So to that extent, don't vilify your opponents and you won't get so much pressure back. Revisit that February meeting of last year to know community does show up when they are needed. Glad this COVID emergency is beyond us. Never was an emergency. And don't ever again use mandates or any lockdowns or force otherwise for any future health emergency. Tell people to get outside, stay healthy, and that's it. And that would be greatly appreciated. Thanks for listening. Highly encourage you, get in person. Greg, make it happen. You say the same spiel every day. September, please make it happen. Let the community show up. There's only a few of us anyways.
30
I
seconds.
don't think anyone else tunes in. Yeah, it would be impactful. And I think your ability or inability to actually reason and talk with us through these issues, that makes movement forward, not disparaging your opponent, not just allowing a comment period with a notice on the front of it of we don't condone, we don't advocate for all these things. So anyways, that spiel's all over the place, but you guys can do a better job. I hope you do. And I'm glad this emergency is over. I don't think there ever was one. And
That's time.
Yeah, thanks.
Thanks, Ryan.
Okay, thank you. Let's see, item 3 on the agenda, 2021 audit results.
Good evening, Board of Health. I'm Lexi Nolan, Deputy Director of Boulder County Public Health and Interim Executive Director. Our first item on the agenda tonight, we have Sam Helwig, Principal at Clifton Larson Allen LLP, to present our 2021 audit findings. Welcome, Sam.
Thanks for having me. Is there any echo on your end, or is the audio coming through? Okay. Very good. And after this presentation, I don't think I have the ability to share my screen. Is there?
Yeah, I
Other
can
pages
start
after
sharing
this?
it for you. Hi, Sam, it's Jordan. I'll go ahead and share my screen.
Perfect. I just want to start by saying, yep, we completed the 2021 financial audit. We know this is as of December 31st, 2021. So 2022, for those who are wondering, the December 31st, 2022 audit is expected to start either in May or June of this year. So we're getting back on track. We know things were extremely hectic and busy over the last couple of years. So we're expected and excited to get back on track with an audit schedule this coming year. So with that, I just wanted to briefly present on the audit going back to December 31st of 2021. So the pages that we have here include the auditor's independent auditor's report. This is on the first couple of pages of the annual financial statements. You'll note that this does reflect the governmental activities and the major fund being the general fund of Boulder County Public Health. These are comparative financial statements for 2021 as well as 2020. So every statement that you see will have 2 statements for both of those years comparatively. So new this year, if you were to compare and go back to last year's, I should say 2020's financial statements in our audit opinion, there was a slight change in the terminology and just the ordering really of this audit report. Basically what happened was it moved the opinion from page 2 or 3 all the way up to the front. So it got to the good news first. So we're happy to report that in our opinion, the financial statements referred to above, meaning the governmental activities and the major fund for those 2 fiscal years, are presented fairly in all material respects. So that's the great news. It's a clean audit opinion. It's what everyone's excited for. So as you scroll down just a little bit, the paragraph just below it is our basis for opinion. And so this is the standards that we measure our audit work against in the financial statements themselves. This was unchanged. It's in accordance with generally accepted auditing standards generally accepted in the United States of America, as well as government auditing standards. So the report at the very back will actually refer to the government auditing standard report, which is over internal control and compliance. I'll get to that in just a moment. So responsibilities for management, there's auditor responsibilities on the next page, but the management responsibilities are what I also wanted to touch on. And that's where management is responsible for the preparation and fair presentation of these financial statements in accordance with those accounting principles that I just previously mentioned. This includes the design, implementation, and maintenance of internal control relative to preparing those financial statements. One other thing that was added as in the last year was related to going concern. This is typically not an issue for governments, but it is something that is now called out in audit opinions. So that last paragraph on this first page discusses that if there was an issue related to going concern for a period of 12 months after our report date, we would have to call that out and subsequently add that to our footnotes. So there was no issue in that regard. You can go to the next page. This also was expanded upon in the new audit opinion format. It basically goes into more auditors' responsibilities and calls out what we do as part of the audit. So although our standards and our exact efforts during the audit procedures didn't change, this is just a more detail about what we actually went through as part of the audit process. So in terms of that first bullet, we exercise professional judgment. We maintain professional skepticism throughout the audit. We assess the risk of material misstatement over the financial statements, whether due to fraud or error. We obtain an understanding of those internal controls set up by management, and we design tests related to that internal control and key balances. And at the very bottom, there we go into the appropriateness of accounting policies and the reasonableness of significant accounting estimates. So I'll go into a little more detail about significant estimates in the governance communication. That'll be the next document I share or go over. But for now, that is the main points that I wanted to go over with our audit responsibilities. And then you can go to the next page. This audit opinion does call out required supplementary information as well. This is as it spells out, the management's discussion and analysis, the schedule of net pension liability, the OPEB schedules, those sorts of things. Those are called out in the table of contents as well as our audit opinion, because those are not part of the basic financial statements. So when we submit our opinion over the basic financial statements, and I apologize, is anybody getting a little feedback there, or is that just me?
It's just you.
Okay. So anything related to the basic financial statements includes the basic financial statements, the balance sheet, the income statement, the statement of net position, and the statement of activities, and the related notes to those financial statements. That's what we issue our opinion over. This required supplementary information. We do perform regular audit tests to tie it into the rest of our audit work, but we do not express an opinion over those statements. And finally, the supplementary information goes into some of those other schedules, such as Boulder County Public Health's general budget to actual schedules. We do issue our opinion. That's in the last sentence where we say the supplementary information is fairly stated in all material respects. So with that, I think the next several pages, this is our entire audit report, includes the audited financial statements for 2021 and 2020. So between pages 6 through 64, I believe, is where you get the various schedules, you get the basic financial statements. I'm not going to go into too much detail with these, other than to highlight on page 6 is where the management's discussion and analysis starts. And if you wanted to go back and look at 2021, 2020 high level, the management's discussion and analysis provides really good depth about what happened in those comparative years. So if you didn't want to go into the details of the basic financial statements, all the notes, this would be a good place to start. So I think at the back, it might be page 64 is our next report. There we go. So this report is in accordance with government auditing standards, and this is associated with, it really just comes up with the receipt and expense of federal dollars. So with these, we do have to perform audit procedures in accordance with GAS is what it's called. So what this report goes into is that it's our evaluation of internal control over financial reporting and on compliance and other matters with GAS. So when we're talking about this, we're not issuing an opinion over internal control, but we're evaluating the internal control environment for any non-compliance related to these auditing standards. So at the very bottom, scroll through, it goes into that, it references our audit report that we had aforementioned. But the beginning here at the very bottom goes into that there was no significant issues identified. What that would be is we would be required to discuss any material weaknesses, any significant deficiencies, either in 2021 or 2020. And what this report summarizes is that there was no significant matters in that regard. So overall, very clean audit, both in 2020 and 2021. I went pretty quickly and over those couple of reports. So any questions before I continue?
Well, I think this is great news because we have had a lot of turnover in this department. So it's great that this came through. I did have a question about in the past, because this is an issue statewide in Colorado. I remember this came up years ago, but just about pension liabilities and whether or not that, I mean, I think it continues to be an issue. Is that part of the audit report?
The pension liability is, so if you were to go to page, let's see. I didn't. So this would be page 12 out of 67. That would be the statement of net position. And you scroll down to the liabilities. And this is where the net pension liability, as well as OPEB, other post-employment benefits. This is where it did become part several years ago when GASB 67 was adopted for every government. The pension and OPEB liabilities were previously not reported on government financial statements, and then the portion that was related to each government was reported. So when you scroll down just a little bit more to the bottom of net position, everybody's net position got skewed and kind of thrown awry because of those liabilities going on to each financial statement. So that's why there's a big negative or deficit net position on just about every government because of that pension and OPEB liability. The messaging, though, is the same, where every year it just becomes part of the contributions that may or may not change, those percentages that go through payroll. In terms of the overall liabilities themselves, it's really not of a risk or concern of those becoming immediately due and payable. There would be no risk from that standpoint. It's just this is a number that you see once a year in audited financial statements. And so I wanted to address that on these, what you would call government-wide financial statements. But if you were to go down 2 or 3 pages to the balance sheet, let's go one more. Yep, here we go. So this would be, if you wanted to look at the general fund, it excludes those long-term liabilities. And this gives you, if you scroll down just a little bit to the overall fund balance, this reflects a more healthy fund balance, a more accurate representation, if you will, of what resources are available for Boulder County Public Health in any given moment. Does that answer your question?
Yeah, it does. Thank you. I mean, I think we still have an issue across sort of government entities in Colorado with pension liability in the long term, right? So, but we're not alone in that.
Correct. That's the ever evolving consideration that must be given out there for, what are going to be the required pension contributions, OPEB contributions, all of that.
Okay, thank you.
What's the time horizon on that? How far out do you look for that liability, Sam?
That's a great question. At the very back, one of the, or a couple of the required supplementary schedules, it might be in the 60s, starting in the 60s. Those schedules go back in time 10 years, including all the required contributions, the history of the pension and OPEB liabilities. So OPEB is more recent, so I don't think there's 10 years of history on that yet. And if I find the exact page for you, that'd probably be helpful. So if you wanted to look, the first page, 51 out of 67, would go into some of that history. But again, this is a historical perspective. It doesn't look out into the future. It's really just something that's assessed every year. And the actuarial reports that are really relied on, those come in typically one year in arrears with roll forward work procedures done. But I know that's always it's tough with, especially over 2022, you're looking at a higher interest rate environment. Obviously, a lot of things have changed there. Contributions change in accordance with those actuarial estimates. So in terms of answering your question in that regard, we don't look out as part of the audit procedures.
Okay, thanks.
Good questions. Anything else in these? Okay. If no more, the other document that I wanted to address was our final governance communication. And a lot of these I already described in some detail, so I can scan over these fairly quickly. There we go. So this is the final part of the audit report. So we issue our audit opinion, but we also have final governance communications with you, the board, over the results of the audit. So this really summarizes the key aspects of any audit documentation. You'll notice it's pretty similar to the one that was issued each year. There weren't too many substantive changes with this document. So if you scroll down just a little bit, the first section goes into aspects of accounting policies and practices. If there was any new accounting policies put into place, let's say management changed a certain aspect of how things were measured, then we would call that out here and express how we ended up going about the audit in that way. So for 2022, a common one that we're seeing for other audits that have been completed was GASB 87 or leases. That's something that we're going to be going into in the future with the 2022 financial statement audit is consideration of leases and both on the lessee side and lessor side. So that's something that I'll be working with Desiree and her team on in the coming future. But that's just an example for reference here. Accounting estimates just down below is what we just talked about regarding the pension and OPEB liabilities. So that's the most significant accounting estimates there. But in all actuality, there's not too many changes there regarding management's estimate in that regard. A lot of that is actuarially driven. Go to the next page. This goes into any significant issues or other conversations that management might have had, we might have had with management. So there was no significant unusual transactions. There was no difficulties encountered in performing the audit other than the delay in time, which is not unusual. And again, we're working to get back on track from that perspective. The next two bullets were uncorrected misstatements and corrected. So with uncorrected misstatements, this is something, and I apologize, that final should have been 16,800, not $16.80. But this is something that was deemed immaterial to the overall financial statements and was passed on recording by management. So this is something that we noted should have not been recorded twice, but it was, and it was not corrected in fiscal 22. So it's one of those that gets corrected going forward. And right below that would be corrected misstatements. If it was deemed material or significant to the financial statements, we would be forced to call that out. And there were no such corrected misstatements. So again, just reiterating, with the turnover, we understand the process was long for closing the books and a long audit process, but overall very clean results from those two sections. The only other two pieces that I wanted to call out was just below it with disagreements with management. There were none. If there were any, we would be calling them out here. And management representations, those go into pages 4 through the last 10. So those would be the bullet points if you wanted to review those, what management has represented as part of the audit, going over things such as assets, liabilities, equity, anything of those representations. That's what management has asserted in the last few pages of that document. Those were the two documents that I wanted to go over today, but I'm happy to field any more questions at this time.
Right, it doesn't look like we have any other questions, Sam. Thank you so much.
Yeah, thanks a lot, Sam.
Thank you all for the time.
See you next, or see you this year.
Hopefully.
Let me know with that, we plan on going into 2022. So if there's any kind of a planning meeting that you want to have or any pre-audit governance communication, I'm happy to go into that. Just let me know.
Great. Thanks, and thanks to everybody on the BCPH team. I know a lot of grant funding was happening during this time, a change in systems, and so that required extra diligence on your part, and there's too many people to thank, but great job, everyone. All right.
And
Item 4.
Before we move to the next agenda item, I believe Desiree and Catherine have a little follow-up.
Oh, okay.
Yeah, I'm Desiree Casarosian, Finance Manager. And I just wanted to give you a quick update where we are with the county on this year's audit. So last year, the audit wasn't issued to the end of the year. So this year, the goal is to issue the audit in July. So BCPH doesn't create our own financials. We hire Clifton Larson Allen to do that for us. So the county is aiming to get their trial balance ready by May 1st. We will probably aim for some time in May. We don't have the same prep after we get the trial balance that they do. So we are working on getting our engagement letter because that hasn't been received yet from Clifton Larson Allen. So I discussed that with Sam on Friday. So we're looking to get that so we can actually get the audit started under our contract. We use them obviously because the county uses them. So we piggyback off of that same contract. The news for us is this year we have a new senior accountant. So we used to have Susan Hyatt, so now we have Jessica Hollinger, and she started a month ago, and she is already deep into audit reconciliations. We are having a weekly meeting with OFM, Alan Smith, and aligning ourselves to the county timelines. Is there anything else I can provide for you? Perfect.
No, just thanks for the
Of course.
work on it.
Right, and I just want to extend the appreciation to the staff. So when this audit was conducted, that was in the middle of an enormous amount of turnover in the NF team, and just kudos to the team for being able to make sure that those puzzle pieces were all fitting together and that the auditors got just what they needed to provide us with that feedback. So thank you so much.
Of course.
Okay. All right, item 4, Public Health Improvement Plan and Strategic Plan Progress Update.
Okay, so in January, we said that we would provide an update in April to the Board of Health on progress on our Public Health Improvement Plan, which is focused on mental and behavioral health, which we are developing as part of a broader strategic plan in coordination with other county departments, as well as provide an update on our broader strategic planning process. We are still aiming to have the Public Health Improvement Plan, or the 5th, largely built out in terms of strategies and priorities by early summer, and our strategic plan by the end of the year. This evening, we have Elise Waln, our health planning and evaluation manager, and Rachel Mental, our health planning and evaluation health planner, to provide updates on both planning processes. And I believe Kelly Hinch, our director of strategic initiatives, will start us off.
Thanks, Lexi. So Kelly Hinch, she, her pronouns, the Strategic Initiatives Director. Before we turn it over to Elise and Rachel, I just wanted to reiterate what Lexi said, that this is a complex process of building our public health improvement plan and our broader strategic plan. And we're building it in a way that we've never done it before as an agency. And I think it's a really unique and interesting ways that are going to really move us forward, or move the needle forward in ways we haven't been able to do so in the past. And so again, Rachel and Elise will give an update, but I do want to send out kudos. I think we have a really dynamite team with both Rachel and Elise, and also Dave LaRocca, who is our mental behavior health coordinator, also on the SIB team. He is joining us remotely. And also to Lexi, who meets with us every week and brings her skill set, significant skill set, I must say, to this discussion as well. So we really appreciate that. So Elise, I'll let you jump in.
Sounds good. Nice to be back and see you all again. Again, my name is Elise Walm, Health Planning and Evaluation Program Manager, she, her, hers pronouns. And as you also have heard, Rachel Mental, our wonderful health planner, who also uses she, her, hers pronouns. We are going to tag team our presentation tonight and give you kind of an update on a lot of the information that we shared with you back in, I think it was February, is actually when we saw you last. So what we've accomplished in the last 2 months and what we are looking ahead to accomplishing. So yeah, you've kind of gotten already a sneak preview of what our purpose is here today, just to provide you on updates on both our public health improvement planning process and our strategic planning process. We're going to try to spend the first 20 to 25 minutes or so providing you those updates, and then leave about 5 to 10 minutes at the end for questions. Go ahead. We'll just go ahead and dive right on it and onto our public health improvement plan. You can go ahead and click ahead. What I wanted to start off with was just a really quick refresher on some of the information we provided last time. So as a reminder, our previous public health improvement plan was wrapped up in December of 2022. And we are in the process of developing our 2023 to 2027 public health improvement plan. And as Lexi already mentioned, hoping to have that finalized by June of this year. Again, this is a mandated activity for all local public health departments here in Colorado to develop our community health assessment and our public health improvement plan, required to do so at a minimum of every 5 years, although some health departments do choose to have a quicker cycle. And here at BCPH, we utilize the Colorado Health Assessment and Planning System to kind of dictate what our process looks like. That is the CHAPS process outlined by CDPHE. Go ahead. Another friendly reminder, our upcoming public health improvement plan will be mental and behavioral health in focus. And when we talk about the area of work that we hope to accomplish, or kind of the wheelhouse of public health in this mental and behavioral health space, we're talking really about focusing our efforts in promotion, prevention, and then this small segment of treatment, namely identification and referral for clients. Go ahead and skip forward. Our colleagues here who have expertise in mental and behavioral health over the past couple of years developed this MBH framework to kind of further codify what our agency's approach is in this mental and behavioral health space. So this MBH framework is intended to guide our organization's MBH work via shared goals, shared coordinated objectives and strategies. And really the hope is that this framework can help us work across the department to align our efforts, identify gaps, and be really strategic when it comes to prioritizing and coordinating funding and resource opportunities. So we're going to talk about this framework a little bit more in just a second, but I really want to highlight that this is a really wonderful resource that our colleagues with expertise developed and is turning into kind of a central tool that we're using in planning for our FIP and ensuring that we are focusing our efforts in the right places and aligning our work with really what is within public health's wheelhouse. So you can go ahead, Jordan. Quick recap on what we've accomplished over February and March. Our HPE staff presented on our CHOFIP process at the Behavioral Health Roadmap Community Meeting. So as a reminder, our colleagues in community services are spearheading and coordinating this countywide effort to develop a behavioral health strategic plan for the county. And so we had the honor of presenting on our process there and speaking to the alignment that we're working towards between our public health improvement plan and the behavioral health roadmap. Omni Institutes are our consultants that we are paying to facilitate our CHOFIP process and working closely with our HPE team. They and our CHOFIP work group have worked diligently over the past several months to continue outreach and engagement efforts in order to bring together all the quantitative and qualitative data that we are pulling together for our community health assessment. The quantitative and qualitative data, the kind of specific piece within our CHA is that's all pulled together in our community health profile. And in addition to that, we've been working with Omni to develop these data snapshots, which I'll talk about more in just a second. And so those were developed for inclusion in our CHA, as well as to help BCPH staff, partners, and community members identify strategies for our public health improvement plan. And last but certainly not least, just want to reiterate again and again that we are working on spending a lot of time working to coordinate with our colleagues over at Community Services to ensure that whatever comes out of our public health improvement plan is highlighted and is represented in some way, shape, or form in that behavioral health roadmap for the county. Go ahead, Jordan. It's buzzing. I'm not sure if that's mine. Looking ahead to activities we're looking forward to accomplishing in April, May, and June. Jordan, do you mind clicking it just one more time? For some reason, I'm not sure why that one was off on a different timer. Apologies. So yeah, looking ahead to April, May, and June, what activities we're looking forward to completing. We're working closely with our CHOFIP work group and with Omni to finalize these data snapshots, to finalize a tool that we're referring to as a strategy crosswalk, and finalizing our capacity assessment, all of these pieces which will be pulled together in our community health assessment and ultimately used to help identify, again, strategies, goals, objectives for our public health improvement plan. Coming up just later this week, we are having an extended CHOFIP work group meeting, which will consist of our BCPH colleagues coming together to review all of that data. So again, data snapshots, strategy crosswalk, capacity assessment, and start that initial dive into, bless you, start that initial dive into, again, the strategies, goals, objectives, activities for our public health improvement plan. Looking ahead to May, we have selected a tentative date for a community gathering where we are looking forward to bringing together BCPH staff, community partners, and community members to again review the data that has been collected so far and drill down even further into the goals, objectives, activities for our public health improvement plan. We are looking forward to hosting that meeting in collaboration with our colleagues over at Community Services who are responsible for the behavioral health roadmap so that, again, we continue to work towards that alignment between what is outlined in our FIP and the prevention and early intervention and harm reduction work kind of outlined in the behavioral health roadmap. And last but certainly not least, like I said, in late June, we're looking forward to the formalization, finalization of the CHA-FIP documents. including the development of our year one action plan. So what does our agency hope to accomplish in the first year of implementing our FIP? And then the next step that I haven't included up there, but is obviously once those documents are all finalized, we would obviously be sharing those with CDPHE. And that's it. Go ahead. I'm not going to spend too long on this slide. Lexi asked me to include this because we had shared this earlier as kind of a high level overview of everything that's coming up in the next couple of months. What the main takeaway here really is that we are working in close partnership again with our colleagues over at Community Services who are facilitating the development of the behavioral health roadmap. And we've just got a tight schedule over the next few months in terms of trying to stay in lockstep with their process, ensuring that we are on time, on scope with our contract with Omni. So we're working very closely in tandem and also working to ensure that all these pieces fall into place. So we've got a lot of work scheduled, but we're really looking forward to this. The color coding is really just to highlight all the activities that are kind of planned for the behavioral health roadmap process. That one orange one is the kind of only in-house, only BCPH focused gathering that we are facilitating. That's the meeting that's happening later this week. But all the purple activities that you see up there are again where we are working very closely with our behavioral health partners, our community service partners to ensure that alignment again between these two plans. So that's why our FIP community event is highlighted in purple, and that we are working closely with Omni to facilitate that, but also hoping to bring in our community service colleagues to contribute to that conversation and speak to what that alignment will look like moving forward. You can go ahead, Jordan. I'm going to try and go really quickly, but I wanted to highlight two of the key data products that Omni and our CHOFIP work group have been working diligently on and that we are looking forward to incorporating into our FIP strategy selection process. Lindy, did you have a question? Oh, we can't hear you, Lindy. I'm sorry. There you go.
Can you hear me now?
Yep.
Hang on. Could you go? There's a really bad feedback. Sorry, Jordan, I'm using my dial-in. Okay, I'm gonna hang up.
Uh-oh.
Is that better? Can you guys hear me?
Yeah, we have no trouble hearing you, Lindy.
Yeah, there's some weird feedback if you're on the phone. I think that was me. Anyway, can you go back to that timeline really quickly? I'm just trying to understand. Is the Board of Health in this process? I'm not seeing it directly, so I just wanted to understand that.
It's not outlined explicitly in this process, but in the timeline right here. But yes, that is a part of our process before sending it off to CDPHE. We developed this one in meeting with our colleagues at Community Services to mainly stay sure that we were on top of what their key dates were and what some of our key internal dates were, especially when working with Omni as part of their contract. But I admit that this doesn't include every single explicit step in our process. But yes, you're correct, Lindy. Sharing our final documentation with the Board of Health is certainly part of our process.
So just like, but I'm clear on our role. We are not weighing in on this plan as the Board of Health.
You will have an opportunity. So in just a second, I'll share that May community meeting. We will certainly be inviting the Board of Health to that May community meeting to view the data and have an opportunity to weigh in on it in that setting. And you will be able to review the final documentation before we share it with CDPHE. And technically, if there was anything at that time that the board found issue with or was not satisfied with, we would need to rectify that before sending it off to the state.
This is for the public health improvement plan, not the strategic plan.
Yes.
Right. I understand that. But if this is a document that we're, given this is such a huge community health priority, I'm just trying to follow along in terms of this process. It's a little confusing to me.
Can you ask more questions or what part's confusing, Lindy?
I thought there would be a sign-off point with the Board of Health on this document before it went forward to like the county commissioners as an example. It sounds like there is an interim step there and it's just not called out.
Yes, and the steps that you see there is we're actually not presenting the public health improvement plan to the Board of Health. That last step there is the behavioral health roadmap. So that again is the community services process. Their plan is going before the county commissioners. And so that was kind of one of the important pieces that we wanted to ensure that our FIP could be finalized and elements from our FIP incorporated into the behavioral health roadmap before it goes before the Board of County Commissioners. But our FIP explicitly is not going before the Board of County Commissioners. Apologies if there was confusion on
And
that plan.
I would expect the full final draft of the FIP to be presented to the Board of Health, probably in the June meeting, for your review and approval.
Yeah, I would say June or July meeting. Depends on the date.
Yeah, apologies. We have two plans, our FIP and then the behavioral health roadmap that sound very similar and do have slightly different processes. So apologies for that, Lindy. We could have made that more explicitly clear. Again, when we originally pulled this together, it was mainly for our team to kind of get a handhold on the numerous meetings coming up in the next several months between ourselves and our community services colleagues. But does that answer your question, Lindy, or was there anything else that felt? Okay.
No, that's helpful. Clarity. It's just hard to discern what document we're talking about when. So yes, thank you.
Totally fair. Next time we can break this out by the different documents themselves.
Yeah, it doesn't look like, looking at this versus what we were provided in the appendix, the dates, it seems like things are either missing or it's not clear.
Or they've been updated since we sent that is perfectly a possibility as well.
Okay.
So this has been a shifting process, as I think Lexi and Kelly can speak to you on, of trying to stay as closely aligned with our community services partners when dates have changed and availability of partners has changed. And so if there are discrepancies, that could be in part, and it's also possible for human error on our part. I can acknowledge that. The timeline, I think what you have probably in your timeline is a more accurate reflection of dates. Some of these, again, are pieces that this was in meeting with our community service colleagues. And since then, some of these dates have changed on their end as well. I think their April 26th meeting has been updated.
Yeah, I think some of these just aren't in our timeline.
Again, because some of these are.
Internal.
Yeah, some of these are specific, the timelines are specific to our process. What we have here is outlining of both of these processes.
Okay. Internal and external.
Yes, yeah. Yeah, and so again, really just what we wanted to highlight here was the quick turnaround of some of these pieces so that we can ultimately, the main goal, not just finalize our public health improvement plan and share with you all and ultimately share with the state, but really ensure that there can be that alignment between our plan and the behavioral health roadmap. There's just been, a present and an ongoing desire to see that our work be represented in there as that moves forward and does get presented to the Board of County Commissioners. And as we do look at future resourcing of that plan and ultimately our public health improvement plan. Does that feel like a fair statement to say, Lexi? Thank you for the questions on this. Next time we will, if we choose to include this slide next time, we will spend some more time in outlining some of the processes, distinguishing between the two processes. Thanks for it.
I mean, sorry, it would be helpful, I think, from a high level, like the FIP it's mostly a data document. Is that fair to say? I mean, it's.
CHA is mostly, so the community health assessment is mostly a data document.
Okay, and then the FIP is how you're going to address the data.
Is the plan. Yeah, that's actually the
okay.
planning portion.
Right. So yeah, there's a lot here.
Oh, yeah, we are well aware of it. There's pieces.
There's a keen awareness of that.
Yeah, and the acronyms are not helpful.
Yes.
Generally, I know this is not acronyms that you have assigned, but
Yeah.
so the CHA is data, the FIP is how you address the CHA, and the FIP and the CHA then influence the strategic plan.
Are part of the strategic plan.
Yeah, okay. Thank you.
And those also feed into this behavioral health roadmap.
Right, okay.
So we're just
yeah.
trying to make it extra complicated for sure.
Yeah.
No, thank you for outlining that way. Thanks, Jordan. All right, diving back into these key data products, I'll try to walk through these quickly. And if there are more questions afterwards on these, happy to provide more information. I want to preface this by saying for both of these documents that we are sharing, or these resources we're sharing, these are very much in draft form. We are in the process of working with Omni as well as our CHOPIP work group and internal colleagues and even some external colleagues to finalize these documents. But you can go ahead, Jordan. The first one we'll chat about are these data snapshots. So what these are they're intended to be 1 to 2 page documents summarizing the quantitative and qualitative data that's been gathered as part of our community health assessment process for those priority populations that were identified as part of our community health assessment process. And the purpose of these snapshots is really to capture high level mental and behavioral health data on strengths and challenges for our priority populations, and kind of an initial synthesis of some of the strategies and recommendations that have emerged from all of the community engagement efforts that have been ongoing. You can go ahead, Jordan. As a quick reminder, these are the priority populations that were identified as part of our community health assessment process. Again, looking ahead to our public health improvement plan, it is anticipated that our public health improvement plan will work to focus on a subset of these priority populations, but not necessarily work to address, work to incorporate efforts that target all of these priority populations. But again, we identified our priority populations based on where we saw discernible disparities in the data, and also where there was a lack of sufficient data and we wanted to explore more. So these are the populations we will be developing data snapshots for. Go ahead, Jordan. And on this next slide, I wanted to share with you just a draft. And I want to reiterate that this is a draft. This is something that has been shared with internal colleagues as well as some external colleagues to proofread for readability. Are we using the correct language in some of these cases? Should we tweak that language at all? Visually, is it easy to decipher? This is something that Omni has really taken on. And the example that you see here is our snapshot for maternal health. And so one side is focused on high-level indicators for mental health, and the other side has high-level indicators for behavioral health. And there, as you'll see for each of those, is a little description to help make it easier to decipher. What are we looking at? What is the time frame we're looking at? Jordan, if you want to skip to the next one. This is obviously a little longer than the 2-pager that we just described. This one is ending up being a 4-pager, it looks like, or at least in draft form. And so what you're seeing on these 2 slides here is the initial synthesis, or the trying to tackle synthesizing all of that qualitative feedback that has been brought together. So this looks like, my understanding is that this is looking at qualitative data that was gathered from focus groups with our Nurse Family Partnership Program, WIC, Genesis, as well as data that has been captured as part of the behavioral health roadmap process. So really trying to tease out some of the themes and the recurring needs that have been identified, recommendations that are emerging from this data. And again, we have our colleagues reviewing this to ensure that this is legible, understandable, that it is presented in a format that they feel that folks will find digestible and able to review in order to make some of those decisions around FIP priorities. Go ahead, Jordan. Jumping ahead real quickly to the second.
How are you defining people affected by climate change?
That is one of the, if you want to go back, Jordan, sorry, and you might need to go back to slide 3. Yeah, so when Omni was reviewing the data for this, there were several topic areas that they felt were so broadly encompassing that they were trying to put, rather than creating its own separate data snapshot, trying to incorporate some of that data within the broader county snapshot. So we don't have a subset of the population per se. It's more trying to look at indicators broadly around climate change impact within Boulder County rather than a specific subset impacted by climate change, if that makes sense. It was one of those topic areas where when we were trying to splice the data, it was like, this is broadly reaching. It makes probably the most sense to capture as part of that broader community context rather than its own data snap sheet, if that makes sense.
Yeah, so like everybody in Boulder County, but you're looking at indicators related to climate change.
Trying to find those indicators that is a crosswalk between climate change and mental behavioral health data. So it is a smaller subset rather than just climate change broadly,
Okay.
but looking at what I think some of the indicators they do have for that one are broad impacts of climate change, but trying to do that crosswalk where we can, where the data is available of the mental and behavioral health impacts of climate change, if that makes sense.
Okay.
I would say also in the future, there's potential to be able to dig deeper in this as we hire and onboard our new climate justice coordinator. We'll have a specific focus on populations that are particularly impacted by climate.
And I also thank you for bringing that up, because I do want to bring up the caveat that, Omni is pulling together these data snapshots with data where available. So we acknowledge that for some of these priority populations, we have quite a bit of both quantitative and qualitative data to pull from. And for some of these, frankly, we have mostly qualitative data to pull from, either because the data is lacking or it's not updated in a timely enough manner to really be relevant to this CHA-FIT process. So to Lexi's point, we acknowledge that there are for some of these populations, I'll bring up the example of homelessness. We don't have great quantitative on the ground data at times for the homeless population. However, we have been able to gather some qualitative data to build out that snapshot, if that makes sense. So we want to be transparent, and Omni wants us to be transparent in that, is that we've tried to pull together kind of the existing data, acknowledging that in some of these spaces, it doesn't always exist to the standard that we would like it to. Thanks, Jordan. Apologies, you're skipping all over the place.
One more.
Thank you. So really quickly, our MBH strategies crosswalk. So I'll summarize this very quickly to say, this is a tool we're hoping, or not we're hoping, this is a tool that we are actively pulling together where we are working to visualize mental and behavioral health strategies and recommendations that again are emerging from the qualitative data that we've collected and from the community engagement that's occurred, and crosswalking those strategies with that MBH framework that we spoke to. And the reason that we're trying to do this is we're trying to ensure that as we're diving into identifying strategies, goals, objectives for our FIP, that we are really ensuring that public health is staying within our swim lane and that we are selecting work and focusing our efforts and energy in areas of work that we think are appropriate for public health, that we have the resources or we have the expertise or we have the connections within the community to really make an impact. So Jordan, if you don't mind skipping ahead to the next slide. I'm not going to share the actual tool itself. And the reason we're not going to share it is because we were worried about anything being misconstrued of that we've already selected these priorities, that these are the things that we've selected and these are going to be finally and formally incorporated into our FIP. It is very much a living document. It is continuing to be fleshed out with more of that qualitative data as it has, as we've been gathering it from partners and from our own processes. So rather than walking through kind of all that's emerged, I was going to give you kind of a sneak preview of some of the strategies that have emerged in some of these spaces. But again, I really just want to reiterate these have not been finalized. These have not been selected for our FIP. It's more just to give you a sense of some of the things that are emerging in some of these spaces. So working from left to right in that foster community connection belonging, one of the themes that has emerged is Spanish language access across all efforts. So community engagement, the services we provide, workforce, cultural competency, things like that. Moving over to increased community capacity and for mental health and resilience, one of the themes that has emerged there is provider training and curriculum in key areas. So we just mentioned cultural responsiveness, but also things such as suicide prevention, trauma-informed practices, positive youth development, person-centered care, things such as that. Moving over to address community conditions and policy. One of the things that has emerged there is advocating for insurance reform. So universal healthcare coverage, more Medicaid covered providers and services, provider reimbursement, treatment coverage, all of those sorts of things. Moving over to increased community engagement, one of the themes that has emerged there is paying peers and people with lived experience to participate in our planning, program development, evaluation efforts, recognizing them as experts with lived experience. Moving over to foster prosperity, just one of the themes that has emerged there was safe and accessible transportation to community services, supports, work. And then moving over to early intervention efforts, just one of the themes that has emerged is community-based mental and behavioral health screenings and evaluations. So that could begin in home settings, school settings, community settings broadly. So again, really high level, just a sneak preview.
How many of the recommendations that are emerging are staff driven versus community driven?
That's a great question. I don't know if I actually have an answer for that. Again, this is intended to be reviewed. The information being captured in here and this tool that we're developing is expected to be reviewed alongside that capacity assessment. And I feel like that's where a lot of those pieces are fleshed out of like, in what of these areas, because we also use this framework as kind of the filter for synthesizing information from our capacity assessment. And so I think what that will help, at least what that should help highlight in some sense is where do we have a lot of capacity along the spectrum and where do we see a gap? But to your question of which of these are more staff BCPH driven versus community driven, I don't know that right off the bat, but I think it's a great consideration for sure.
Yeah, and I'll just add that in addition to the process of kind of identifying what the themes that are emerging are and kind of where is our opportunity to either double down in capacity that we have or to develop capacity if something's really important. part of the value of aligning with the behavioral health roadmap, the broader plan, and all of the community engagement processes that we're using is that we can identify where other folks are filling some of those roles so that we're not doing duplication. So for instance, there's, a bill right now with the legislature that would provide screenings to students. Obviously, we wouldn't want to advocate for that bill if it goes through, but there may be those kind of attention to where other community processes are happening and what's our role in supporting those processes, even if we're not leading it.
And I will say that as some of the criteria that our BCP staff will be looking at in terms of prioritization, one of those is around capacity. And it's one of the ways we've looked at it is, do we have capacity in-house? But I think there is an opportunity here to maybe say, is there capacity in-house, or is there opportunities to support this work elsewhere? I think we do want to be very mindful of capacity because oftentimes, as you all are probably aware, sometimes these plans can end up becoming wish lists more than actionable plans. And so I think that is why we do have capacity top of mind is, where do we have existing capacity, or where are there opportunities to acquire the capacity, whether it be resources or manpower or whatever the needed resource is. So, but I think it's a fair point of having that in the back of our mind when we think about capacity.
Yeah, no, I think it's great to think about capacity. I think my question is more coming from a place of just trying to understand the origins of some of the things that are being identified under each category. Is it that community, through Omni's community engagement or through community engagement meetings, that these recommendations are coming forward? Or is it staff bringing these recommendations forward based on their own experience within the community?
Got you.
So trying to understand the balance of where those are coming from. And then, of course, I want you all to be thinking about capacity. That's really important. So, and who else might be doing it, but just trying to understand where the origins of those are.
And it's a mix of both is what I would say. To be perfectly transparent, for some of these areas of work, again, they are likely to be more staff heavy than community member heavy. And that's, again, part of the reason why we wanted to use the framework as filtering these recommendations as they're coming in, because for the recommendations that are coming from the general public does not always have an understanding of public health's wheelhouse. And so there have been things that have emerged in some of these community engagement spaces where we're like, that's not really something that we are equipped to provide, or that maybe we have partners that are much better suited for providing that. And so essentially this has been kind of, again, another way to ensure that we're grounded in whatever we do want to consider for prioritization is within our wheelhouse. So I guess to answer your question, we've tried to strike a balance with both of community identified solution as well as community partners and community partners and staff that have been engaged in the process as well. Did that answer your question?
Yeah, I mean, thank you. I appreciate this. Yep.
Okay. You sure?
I mean, I think I have additional questions, but I'm not sure that you can answer them. So it's okay. I think that, I guess it's so important, I think, to engage the community in the process. So it sounds like there are opportunities for the community to engage in the process and for us to be capturing their input.
Yeah, just really quick, I just want to say we'd be happy, to connect with you even outside the meeting and walk you through spaces, and also understand that we're seeing this as community engagement that's ongoing. It's not just community engagement to get to here to the plan. It's that in this plan is a living document. So community engagement also to tweak and to, maybe we start off down a path and decide to come back because there's somebody else already on the path or whatever. So.
Thanks. For sure. Go ahead, Jordan. I'm gonna try and wrap it up so I can get to poor Rachel's portion of the presentation. Really high level summarizing again, both of the data snapshots as well as the strategies crosswalk in combination with that capacity assessment. All of that information is being brought together by Omni to facilitate some of these prioritization conversations. So the plan is for initially later this week for our staff to start engaging in that process. But then again, looking ahead to May, we're looking forward to staff, partners, and community members to be involved in the formalization of those goals, objectives, and activities. Go ahead, Jordan. I'll wrap things up by, again, very high level next steps for these tools, which is kind of a repeat in some ways of, the next steps for our CHOFIP process generally. But tomorrow, I keep forgetting that today is the 10th now. Tomorrow is when those data snapshots are going to be finalized. Again, Omni has been working with our CHOFIP work group as well as some external partners to finalize that language, ensure it's appropriate, approachable. Later this week, again, we're going to be using those data snapshots, the capacity assessment, strategy crosswalk to start the process of identifying priorities and high-level goals for our FIP. Again, looking ahead to May is when we're looking forward to using all these resources again, but again, diving even deeper into goals, objectives, and activities for the FIP with community partners, our BCH staff, and certainly community members. And again, would love to extend an invitation to you all to join that meeting. Again, this is still a slightly tentative date, but I think we are very close to having it be finalized. We were just waiting for some final feedback from our CHOFIP work group to make sure we weren't missing some large community event that we wanted to not overlap with. But again, would really encourage the Board of Health. Once that's finalized, we'll certainly forward the invitation to that, to the Board of Health, and would love to have you attend if you're interested. And then again, in terms of next steps specifically for these data products, we're looking forward to sharing those data snapshots on our website once all of our documentation is finalized, so that our partners and staff, if they would like to access that data, have it available and utilize it for their own individual programs and projects. Thanks, Jordan.
All right, now it's my turn. Hi, everyone. Again, I'm Rachel, the health planner. Nice to meet you all. This is my first time being here with you all at the Board of Health meeting. So I only have a few slides to present on. I lucked out and got the shorter part of the presentation. So I'm just going to provide a little bit of an update on our strategic plan, one of the many planning components that we are working on. You can go to the next slide. Thank you. So a quick reminder that we are in the process of developing our strategic plan that will operate from 2024 through 2028. And our goal is to have this document finalized in December of 2023, at the end of this year. While this is not mandated like the CHOFIP process is, still a core public health capability and best practice for local public health departments to have a strategic plan. I guess one positive to it not being mandated is that we are not on the strict timeline that it has to be completed this year like our FIP. So we do have a little bit of flexibility. We're still aiming for that December timeline, but we have that flexibility. Next slide, please. All right, so this is a graphic that might kind of help illustrate, Morgan, your the many pieces coming together. And I think you guys have seen this graphic before with our strategic plan right in the center. And then we have our strategic priorities on the outside. So if you look in the upper right-hand corner, that mental behavioral health, as Elise just outlined, is our FIP topic, our FIP focus area, which also aligns with the county's behavioral health roadmaps. That's kind of how they all fit in together. The other strategic priorities that we have in our strategic plan, going counterclockwise, we have climate action or climate justice, health and racial equity, sustainability, transparency, and stewardship. And then the yellow circle, the additional priorities, community engagement, policy, and emergency preparedness and response. And I'll give you an update kind of on the next slide as to where we're at with those additional priorities. But again, these are just our strategic priorities and how they kind of align with our FIP process, as well as the behavioral health roadmap. Back to the next slide, please. All right, so some activities that we've completed in the last couple of months since Elise last presented to you all. The management team and the respective division leadership teams have had a chance to review our project charter. The HPE team created a roles and responsibilities document. So this really just outlined the scope of work that the work groups are going to be completing around each strategic priority. We also completed a really high-level assessment on where things are at with each of our strategic priorities to kind of help us make some decisions moving forward. Kind of asking questions of, is there already a work group or committee around the strategic priority? How many people are working on it? Are there any goals, objectives, or strategic plans already in the process? So again, that kind of helped create some awareness so we could make decisions moving forward and will help us as we stand up these work groups. And then just last week, the management team determined our next steps for the agency priorities. So those three priorities in the yellow circle, community engagement and emergency preparedness and response, are going to be incorporated into our strategic plan. So they will join the other four priorities, strategic priorities. Policy is kind of tabled at the moment. There were just a lot of external factors going on with that it didn't feel like a good fit for the strategic plan at this moment. Next. You can click a couple more time, one more time. Okay, thanks. Okay, so what we're working on in the next couple of months, really the focus is on establishing these work groups and getting going with that. Tomorrow, April 11th, we're anticipating that our project charter will be finalized by the management team, as well as we'll have kind of a roster of participants for the work groups. So the participants are all BCPH staff, subject matter experts, staff that are already working in each strategic priority area, or will be doing the work moving forward in that area. Kind of a subset of those groups help us create the goals, objectives, and first year detailed implementation plan. So these will not be completed by April 30th, but the work groups will be started by April 30th. So this is a process that's going to take a few months to kind of look at the data and then as a group develop these goals, objectives, and the action plan. And then also by the end of this month, we are hoping to have our staff and community input process outlined, kind of when we're going to start asking for staff and community input and what that's going to look like. Next slide, please. 4. So these are just kind of some high level next steps for both the strategic plan and our FIP process. Elise and I, the HPE team, will continue facilitating and monitoring all the activities going on for the FIP and the strategic plan. Again, a lot of the strategic plan is going to be focusing on getting those work groups up and going. And we would like to invite ourselves back, if possible, in June to give you guys an update, just like we did tonight, on where we're at with the public health improvement plan, which should be pretty close to being done and finalized at that point. And then we can give you guys an update on how the work groups are going with the strategic plan, as well as some of the other progress that we've made in the last couple of months.
Yeah, thank you, Rachel. I just want to add also that as part of this process, it's not only the working groups around those priorities, but we're also looking at building the sustainability piece of that plan, the monitoring evaluation piece of that plan, the programmatic strategic budget piece of that. So there's lots of moving parts and pieces we'll be looking at over the next several months that may not necessarily have a work group, but maybe have a smaller, team working in a space as well. Evelyn's going to be on all those, but.
Surprise. Can we go ahead to the next slide, Rita? Thanks. And that's it. Told you I had the shortest section.
Yeah, and thank you for, I apologize. I definitely took up the majority of our time here today. And I know we've kind of extended our time, our allotted time. So if there are any further questions, please don't hesitate to reach out. Again, we are happy to connect one-on-one via an email, whatever format makes the most sense for answering more questions. I know that there's a lot going on in these processes. We try to be succinct in presenting where we are at and next steps, but always recognize that, as Kelly has said numerous times, these are complex processes and want to make sure that you all feel that you have the information you need to feel comfortable in how we're moving forward. But with that, I think that's it from us, unless there are any final questions, or I'm sure we probably have gone over time.
Yeah, so if you have any, feel free to email me and they can be included in the MATES director's report as well.
Okay. Thank you for keeping us honest and on time. Thanks, Jordan.
Any additional questions? Okay, not seeing any. Okay. We will move on to agenda item 5, which is a program spotlight, COVID-19 transition, stability plan, and emergency preparedness response, strategic priorities, and rebuilding plan. Ooh, that's a mouthful. All right, take it away.
It is. So finally, this evening, we have a program spotlight on the communicable disease and emergency management team. Following our presentation last month related to some of the other impacts related to the end of the public health emergency, which is slated to end in May, the communicable disease team will provide an update tonight on the COVID-19 transition plan and where public health expects to have continued response. Additionally, we'll have, I'll have a quick update from the emergency management team on why we will be digging deep this year on an updated emergency management response and recovery plan as one of our strategic priorities and how we'll be approaching it. So to get us started, Steffi Goodman, Colleen Sinclair, Stacy Farman, Carol Helwig, and Keith Rawls will present on the COVID transition plan on behalf of that team, and Chris Campbell will present on behalf of our emergency management team. So happy to turn it over to you all.
Fantastic. Thank you, Lexi. Good evening to the Board of Health. I know you have had a long day today, so thanks again for your time tonight. My name is Colleen Sinclair. I'm an emergency management planner with Communicable Diseases and Emergency Management Division, and help to facilitate this, our third iteration of pandemic planning efforts. Like Lexi said, I'll be joined tonight by several of the CDEM subject matter experts in our presentation. You can go ahead and go to the next slide, Jordan. Thank you. Actually, you can, one more, please. Thanks. So after 3 years of continuous response operations, including 3 catastrophic fires, a mass casualty event, and layered emergent pathogenic threats such as Mpox, we're really humbled to reach this milestone where we begin to transition out of expanded operations and embark on the process of stabilizing our core programming. This transition is part of a multi-year commitment to pivoting strategies, planning for the future, and evaluating our current efforts to make process improvements. So this journey of transition and stabilization for Boulder County Public Health is aligned with the sunsetting of the state and federal public health emergencies on May 11th. While the World Health Organization still defines COVID as a global pandemic, this timing represents us entering into a period of pandemic recovery, one that will impact the community and public health. So public health strategies and goals recognize changes associated with impacts such as fiscal cliffs, the first of which will initiate this summer. And it also recognizes changes in strategy as free vaccines, therapeutics, and tests are going away. As we make this transition, resources are going to become extremely limited, and our focus will be on priority populations and priority settings, shifting to those who are most at risk and in need. So tonight, we're going to focus on some of our key strategies, including testing, therapeutics, epidemiology, immunizations, and communications. And next slide, please, Jordan. So, well, I know you all have heard a lot of detail from Lexi last month on the impacts of the end of the public health emergency declarations. And while we can identify specific impacts at the end of the PHE, we also acknowledge that questions remain. So it'll be necessary for us to be nimble, continue to monitor those changes in the coming months and how they'll affect our community. We recognize, like I said, that the pandemic has not ended. Our agency just now has the opportunity to transition into some of our core functions. You'll hear me say this a lot throughout the presentation, but a large component of this plan will be communicating these changes to our partners and the public to ensure continued access to testing and therapeutics and immunizations, especially to those priority populations and priority settings. Next slide, please. So as you all know or well are aware, Boulder County Public Health routinely pivoted to change strategies and direction with the changing landscape of COVID-19. You can go ahead to the next slide, please. So throughout the pandemic, Public Health Emergency Management Team has been committed to ensuring we regularly assessed our current challenges and pivoted according to changing needs. So those planning efforts often took months to lead and was aligned with the agency's commitment to participatory leadership, in which all programmatic staff contributed to strategy formation. So we conducted 3 plans, illustrated here. In 2021, we wrote the recovery plan. At that point, 70% of the community was vaccinated with at least 1 dose. This plan adopted a pandemic framework that honored that the pandemic would cycle up and down, which is exactly what we saw with variants in the winter months. In 2022, we engaged in a series of action planning sessions that helped to realign all epidemiology, emergency management, and immunization work with shifts in state guidance and the governor's roadmap. In 2023, we're now in a position to roll out the transition and stabilization plan that recognizes changes in funding and a move towards working with limited priority populations and specific priority settings. In addition to these plans, Chris Campbell and the emergency management team conducted many after action reviews, which are continuous quality improvement activities. And these reviews helped us as an agency to evaluate the work with our community partners and make shifts and pivots to ensure strong community response. And with that, I am going to pass it on to Steffi to talk about community impacts. Thank you.
Thank you, Colleen, and members of the Board of Health. I am Steffi Goodman, pronouns she, hers, data surveillance epidemiologist at BCPH, and I'm going to present a brief recap of community impacts and public health responses associated with the end of the Public Health Declaration. Next slide, please. So as the time draws near for the end of the Public Health Declaration, we want to clarify a few important points. Is there an echo?
Yeah, I think the folks online can hear that echo.
I'll turn off my camera just so that it might help. But a few important points to clarify would be that, as Colleen mentioned, the public health emergency declaration is ending, but the COVID pandemic is not and remains a public health priority, although we are certainly in a much better place than we were in 2020. The Public Health Declaration was intended to provide resources, waivers, and flexibilities to be enacted and carried out by public health agencies and healthcare systems so that Americans, regardless of socioeconomic status and other factors, had access to care and resources during the pandemic. And with the end of the public health emergency, many of those directives dictated by the state or the U.S. government for public health action have ended and are transitioning back into healthcare systems and commercial markets. And as Colleen noted, while we can identify specific impacts resulting from the end of the Public Health Emergency Declaration, we also acknowledge that the roadmap ahead may leave us with many questions. And so we will continue to monitor for impacts to our community in the coming months and be ready to pivot as necessary. Next slide, please. As the time draws, at the last Board of Health meeting in March, Lexi presented slides on the community impacts and some details on public health's response to the end of the public health emergency. She presented some information on the transition of supports like vaccines, therapeutics, testing to healthcare systems, to commercial markets and insurance, both public and private. And last month's presentation also focused on program updates within our public health agency that address community impacts on issues like housing stability, food security, and access to care. And although we don't have all the answers, we continue our efforts internally and with our external partners to promote health equity. Next slide, please. And as Colleen mentioned, moving forward, we are going to be seeing a shift from priority population focus to priority settings. What we mean by that is that throughout the pandemic, we basically structured our response to support those who were at greatest risk for COVID transmission, hospitalization, and death from COVID, as well as populations who may have reason to mistrust healthcare interventions. Our focus has been to use a public health and health equity lens as we focused on people living and working in congregate settings, referred to as our priority settings, along with people who were at highest risk for contracting the disease and having the worst health outcomes, such as hospitalization and death. And these were referred to as priority populations. And as we enter into this transition phase, there is a lot of discussion about the shift away from a priority population focus into priority settings focus. And so I just wanted to take a moment to clarify what we mean with respect to our plans moving forward. Next slide, please, Jordan. And with increasing scarcity of resources within the agency, we'll narrow down the priority populations list that you can see on the right side of this chart, and focus on actually the left side, sorry. And we'll focus on things like access to free vaccines to these populations and ongoing communications. And on the right side of the chart, we define priority settings such as jails, shelters, long-term care facilities, and other congregate living settings, which have substantial impacts on public health. And we will continue to investigate outbreaks in and provide support to people living and working in priority settings as mandated by the state. We are currently awaiting guidance on vaccine availability and accessibility for these settings from the state. Next slide, please. Just wanted to share a couple of illustrations that helped us decide where to focus our interventions on certain populations. The graph on the left, the orange line shows the vaccine uptake in Hispanic populations lagged behind other populations in Boulder County, whereas the map on the right shows how we created maps of vaccine rates by zip code, age, and social vulnerability index in order to target interventions among certain populations. And then the next slide, please. This slide illustrates the reason why focusing on priority settings is so crucial, noting that the outbreaks in these settings increased rapidly during the pandemic, leaving those facilities in dire need of help and support, particularly within like long-term care facilities, correctional centers, shelters, and early care and education, school settings, healthcare settings. And our focus will be on these priority settings as we moved into this next transition period. And thank you. And with that, I will pass it back to you, Colleen.
Awesome. Thank you, Steffi. Thanks for that background. With this background in mind, we'd like to go over agency strategies developed by individual teams during this planning process to adjust to the changes we'll see as a result of the federal and state declarations ending in May. Next slide, please. First, I'll be covering the community impacts and agency response and changes in access to testing and therapeutics. So, and I do want to just give a quick pat on the back to Boulder County Public Health. Well over 500,000 PCR tests were accessed at multiple sites over the course of the pandemic, which I think is something to be really proud of. The ending of the public health emergency declaration will impact community members' access to testing with respect to their payer source. So Medicare will cover provider ordered tests only. Medicaid will continue covering testing through the end of September 2024, and then private insurance companies will determine the cost to beneficiaries. So as far as our response goes, we will be connecting with our community partners to make sure they're taking advantage of the remaining supplies of rapid antigen tests from the state. We'll do more research into what's called ICAT, or Increased Community Access to Testing Opportunities. Those are through two organizations, Color Health and LTS, who are agencies contracted through the CDC for this ICAT program, and then linking them with partner organizations, since funding for these programs will not be affected by the end of the public health emergency declaration. You'll hear me continue to talk about communications, but we'll want to make sure we communicate with the public on how to access tests, and also to encourage personal responsibility for testing so people can self-isolate and then prevent further disease spread. Public health will also continue to monitor reporting requirements for tests, which are ending at the federal level, but will remain in the state of Colorado on a slightly different cadence, and that will be reevaluated sometime this summer. Next slide, please, Jordan. So although the end of the public health emergency won't directly impact therapeutics, looking forward, there will be some changes coming. Right now, the federal government has a large stockpile of oral antivirals and is working with stakeholders to ensure equitable access to therapeutics. They'll remain free until those stockpiles are depleted or commercialization of these medications occurs. The emergency use authorization, for medications are not ending on May 11th. The commercialization of therapeutics is anticipated to end at the end of 2023, at which time pharmaceutical companies will determine pricing. Private insurance companies will determine the cost sharing for their beneficiaries. Medicare recipients will likely have to pay a portion of their therapeutics, and then Medicaid will reimburse for treatments only approved with full FDA approval. So right now that's Veklury or remdesivir. And then the states will determine if medications covered under the emergency use authorization, I don't know why I'm stumbling there, will be covered. That's Paxlovid and Lagevrio. So right now, most community members are accessing therapeutics through their providers, telehealth visits, or the test to treat sites that are in nearby counties. These are likely ending, but we just do not have a definitive timeline. Public health will continue to monitor changes with respect to therapeutic efficacy, new treatments, and changes to existing treatments. We'll continue to communicate information to the community members, encouraging them to have a plan on what to do if they get sick, provide resources for accessing healthcare when needed, review changes and treatment guidelines. And in addition, public health will work to monitor health outcome inequities related to access to therapeutics and work with the uninsured or underinsured members to assist them with access to care. So public health will continue to work with leadership of our healthcare providers' facilities, most importantly, our federally qualified health centers, to address the needs of our community members. And I will send it over to you, Keith, to talk about immunizations. Thank you all.
Hello, everyone. I'm Keith Rawls. I'm the immunization program coordinator. I use pronouns he, him. Next slide, please. The immunization program is in a season of transition from COVID response to a routine vaccination cadence. The immunization team met to reestablish goals for this transition. These goals include the following. 1, reignite the immunization coalition and connect with partners. 2, connect to offer vaccines for low-income children on Medicaid. 3, integrate COVID vaccination appointments into our vaccines for children clinics. 4, execute a fall strategy. 5, develop a communications campaign. Next slide, please. Oh, thank you. Over the past few years, the immunization program responded to changing needs. This included, ramping up for a mass vaccination campaign, responding to lulls over the summer and peaks in demand in the winter. We are now in a stable environment for staffing to respond to a seasonal approach to respiratory season. In lieu of the public health declaration ending, we will likely have challenges with getting free vaccine for the broader community and will need to shift strategy to prioritize specific settings and populations. I'll know more over the summer, as Steffi alluded to, as CDPHE is waiting to hear from the CDC about additional vaccine stockpiles. The immunization team successfully pivoted from evening clinics at the hub to incorporate COVID vaccine appointments into VOC clinics on Mondays and Wednesdays. At this time, we do not plan to run any additional COVID vaccination clinics this fall at the hub. Instead, we will focus our limited stockpile of vaccine in community settings. In summary, the immunization program will continue to provide vaccines to uninsured and underinsured populations of Boulder County and will remain agile in this space. Thank you, folks. Back to you all.
Good evening, everyone. I'm Stacy Farman. I'm an epidemiologist with communicable disease, focusing on congregate settings. And we're going to talk a little bit about the epidemiology infection prevention, surveillance, resource navigation in the call center. Next. So our EPI approach has shifted over time from a draconian hammer to protect the healthcare system when we were all susceptible to severe illness and death, to over time, increased vaccination uptake and more widespread access to therapeutics led to improvements in the population's susceptibility to COVID, which in turn led to reduced severity of impacts of healthcare systems, disease, and death, leading to shifts in our EPI response. The shifts in the trajectory have required an adaptive approach, leadership style, and mindset. The guidance changes for the public and the sectors that we work with were almost constant, and usually were probably on a Friday afternoon. It has been our relationships with our key partners in priority sectors that have helped us to be successful in adapting to these changes. Next slide. Thank you. This slide illustrates how ongoing COVID response needs will continue for our team. In 2022, BCPH investigated a total of 403 outbreaks at a rate of 122 outbreaks per 100,000 population. This reflects an increase over the pre-pandemic 5-year average of 19.2 per year by just under 2,000%. While outbreaks caused by COVID accounted for 80% of reported outbreaks, there was also an uptick in non-COVID respiratory outbreaks and enteric outbreaks in 2022 compared to previous years. Next slide. We will continue to respond to outbreaks in priority settings and need to continue fostering our relationship with key partners that became stronger during the pandemic. Our community benefited from the strong collaboration with various partners such as CIDR, which engages our healthcare infection preventionists and ID docs, our long-term care facilities, and other congregate settings such as the jail. We hope to ensure adequate response no matter the threats that continue to emerge. Thank you. I'll turn it back over to Colleen.
Jump in with a question.
There you go.
I know, sorry.
Sure.
I know we're on a tight time frame
Yeah.
and I asked a lot of questions. Sorry.
No, it's good.
So I'm curious about the increase in outbreak reporting outside of COVID. And I know that because I have young children, I mean, I know there was increases in respiratory viruses and whether or not that's related to sort of our lockdown years and all of that. But I am curious as to whether or not just the overall increase in awareness of public health and then the relationship with BCPH because of COVID is going to mean that we will continue to sort of hear from folks when there are outbreaks around other things other than COVID, like whether or not that's just a new normal in terms of communication that maybe we had outbreaks. So it would be interesting to hear from you on that.
Yeah, I agree with you. I think when before the pandemic, we had relationships, but they weren't as strong with our community partners. And then, but once we had this close, intense relationship with these community partners, they really saw the value in looping us into other outbreaks. So now we have, our ECEs and our long-term cares who are reporting things that they probably didn't report in the past. And I do think this is probably a new normal for us, that we will continue to see more outbreaks in non-COVID settings. So
I would say it's also a function of a changing environment where outbreaks are just going to actually be more common too, in addition to just awareness about the reporting of outbreaks. We know that, if we can get to Chris's presentation tonight, we know that climate change, for instance, significantly impacts outbreaks.
Yeah, no, I'm just thinking about like our ECE setting for my kids that just, I think that the relationship that they now have with BCPH because of COVID means that they are now monitoring and reporting back on a lot of other related or non-COVID outbreaks that are happening. So thank you. I think it's interesting.
Thank you for that question. Any other questions? All right, I'll go ahead and I'll turn it back over to Colleen.
All right, thank you, Stacy. So thanks again for your time tonight, everyone. We'll wrap up with just a brief statement about the communication strategies. Next slide, Jordan. So many of the presenters today, including myself, have mentioned the importance of communication, especially over the next several months while we're seeing all of these changes. So to reiterate, we'll be seeing changes on how our community accesses testing, treatment, and vaccination. So it's going to be exceedingly important for us as an agency to disseminate this information to the community and to our partners. And we'll accomplish that through the numerous avenues that we have listed here to reach folks in whatever way they access this information. And next slide, please, Jordan. So I just wanted to take this opportunity to thank and congratulate all of our staff on their work to reach this point in an unprecedented public health event that will have recovery efforts lasting for many years to come. It will require incredible adjustments on behalf of the agency, the community itself, as well as our healthcare partners. And as we initiate transitional operations, the Communicable Disease and Emergency Management team will be taking time to celebrate staff and their families for all of the sacrifice and dedication. We'll honor the resiliency of these staff, many who maintained these continuous response operations over 3 years through relentless ups and downs, monkey wrenches, curveballs, and entire leadership changes. We really want to thank the board for your support in recognizing our staff and for your time today. So if at this time, if there are any other specific questions, we're happy to try and answer them, or we can get back to you at a later date.
So I just want to take a pulse check because I recognize that it's late. We have one more presentation. It's 6 slides. We are happy to push through with you, or if you would prefer to move it to our May agenda, we can do that too. It's really up to the board.
Chris has waited, so I'm okay, but I will bolt out at 7:30, but I don't think,
I think we can.
I think we can finish by then.
Thank you.
Okay. Well, good evening, and I really appreciate the opportunity. It's great to see the board members this evening, and what also it's great to good evening to community members that are sticking with us. I'll jump right into it. Excuse me. My name is Chris Campbell. I'm the emergency manager with Boulder County Public Health. He, him, his. Also joining this evening is Carrie Middleton, the emergency management planner with Boulder County Public Health. We really appreciate the opportunity this evening to present an overview of our emergency preparedness response and recovery strategic plan. You've seen kind of the setting of building up to this plan. So this evening, we're going to be providing just a real quick overview for the board. Carrie's going to provide just a quick overview of the plan. I'm just going to quickly provide a broader context that has brought us to this 5-year strategic plan. Next slide, please. Thank you. So just to frame our conversation this evening, we just want to highlight that as the pandemic continues to evolve, we're really rebuilding. We're rebuilding in the context of a new landscape that is really framed by climate impacts and multiple long-term recoveries, where you've heard the board is definitely following, of course, the Marshall Fire recovery. This really is going to be an unprecedented recovery from this pandemic response. And a lot of things you hear tonight are initiatives and approaches that we're working on as we roll into recovery. That is the context we're in right now. We know this work in this new landscape is resource intensive, not only for our agency, but for our community partners and the greater community as well. Next slide, please. So broadly, we need to plan for climate adaptation. We know that climate change impacts a wide range of health outcomes. And this graphic really illustrates the significant most significant climate change impacts: rising temperatures, more extreme weather, rising sea levels, increasing carbon dioxide levels. It also shows the effects of exposures to community members and the subsequent health outcomes that can result from these changes. So to really bring that down then to our community, we know that disasters and incidents in Boulder County are not going away, and emergency preparedness and response and recovery are in very high demand. So from a public health perspective, and again, the board is very aware of this. We've supported the 2013 flood, Cowwood, 4 Mile, Encar, Marshall fires, 2 ricin poisonings, a widespread hepatitis A outbreak, meningococcal disease outbreak, the Mpox outbreak, the Table Mesa mass shooting, an RSV pediatric surge, and of course the COVID-19 pandemic. That is a lot for our community in the last decade. We know that climate change has not only led to increased extreme weather, but is also worsening infectious disease patterns and is increasing the risk for future natural and man-made disasters in Boulder County. The next slide, please. Just as a reminder, our role as public health and emergency and disasters is framed or is an all hazards approach. So we respond to floods, fires, infectious disease outbreaks, mass casualty events, drug-related outbreaks, extreme heat, and hazmat incidents. And our focus is specifically on the public health and medical aspects of those hazards. More specifically, these hazards include mitigating the impacts on environmental health, supporting the healthcare system, including hospitals and long-term care homes impacted by an emergency, providing medical countermeasures such as mass prophylaxis, and supporting community members with access and functional needs such as mobility challenges. We are really seen as leaders in Boulder County. We play a role and are seen as leaders for the overall response in many of these disasters and incidents. We're also seen as leaders in the region and as statewide responses as well. Next slide, please. So we just we're getting to the plan details here, and we just wanted to frame how the plan is came together and kind of the landscape we're looking at. But ultimately, the goal of our strategic plan for emergency preparedness, response, and recovery is to truly improve and create systemic changes in our community. We know that these systemic changes will really reach and create the best possible outcomes for everyone. So we also know that there's some negative outcomes should we not invest in these systemic changes. I think many of the board has heard in the community about staff burnout throughout a sustained and long-term emergency response, repeated emergency responses. You heard the list, as you all know well, over the last decade. And we've also had, which does equal and can lead to a loss of institutional knowledge. This is really challenging for an agency. Not investing in these systems changes impacts relationships with key community partners. We have seen difficulty in operationalizing our equity values and may see missed opportunities due to delays and inefficiencies. And we're proud of how we've really come to the priorities in this plan. So it has been mentioned, we emphasize, and the board has definitely heard about our after action reviews and our process, really emphasize an approach of continuous quality improvement. So we have engaged in several of these after action processes in the last 3 years. We celebrate our successes in those, and we look very hardly at how we can improve as an agency, as a community, working with our community partners. So that is how we came about the priorities, and Carrie's going to give you some details on these priorities coming up next. Thanks so much.
Yeah, good evening, everybody. My name is Carrie Middleton, and as Chris mentioned, I'm an emergency management planner, she, her, hers, and I know it's been a long evening and it's coming on quarter after 7, so we appreciate your continued time. Jordan, if you could move to the next slide, please. So as Chris mentioned, in the interest of time, we're not going to go into high levels of detail about these priorities, but we did want to hit some of the highlights. So one component of our rebuilding and recovery is updating our various emergency plans and related agreements with partners. So as you would expect, we have various emergency plans and agreements, and many of them have not been updated for a long time. And just to illustrate that, our public health emergency operations plan, which is the foundation of emergency response, was last updated in 2016. So we all know a lot's happened in the past 3 years alone. So there really is a need to revise and update those plans and agreements, not least to integrate those best practices that we know of based on the lessons learned of past responses. A second recommended priority focuses on our own internal at BCPH administrative and fiscal systems. So clearly these systems impact emergency and recovery operations. So a quick example of that is we have seen sometimes a need to rapidly hire staff. And so we saw this during the COVID-19 pandemic when we quickly had to hire contact tracers and immunization nurses. We've also seen this need for rapid hiring during the Marshall Fire recovery. And unfortunately, our systems are not necessarily set up for quickly hiring and getting people on board in the context of a disaster or an emergency. So that's just illustrative. In general, we're recommending improvements in these systems that will result in greater efficiencies and ultimately improved response and recovery outcomes. I won't spend a lot of time on our third priority. As Chris mentioned, in this changed landscape due to climate change, it's resource intensive, emergency preparedness, response and recovery. And so we're recommending that we identify what resource needs we have to be sure that we are adequately resourced to meet community needs during emergencies and disasters. Jordan, if you would go to the next slide. Our fourth priority, strengthening community partnerships. So I think we're all very well aware that BCPH, we don't, excuse me, we don't repair for, we don't respond to, and we don't recover all by ourselves from emergencies and disasters. And so we recommend that we really just look to continue to strengthen those community partnerships. During our Mpox response, formerly known as monkeypox, as an example, we worked very closely with community partners and ambassadors, and it was their work that especially allowed us to reach and support priority populations. And that response was an instance of us operationalizing equity. And we know that in general, that we do need community partners and community ambassador support to operationalize that equity value. So we definitely want to emphasize that. And then finally, we also see a need to develop a staffing and resiliency plan, one that allows not just for the short-term responses, but also long-term responses and recoveries that we've seen during the pandemic, that we've seen during Marshall. Plans that are sustainable to support those kinds of responses and recoveries, or put another way, plans that avoid that significant burnout and staff turnover that Chris alluded to briefly before, and that we've seen again, especially with the COVID-19 pandemic and the Marshall Fire response and recovery. Jordan, if you could go to the next slide. Thank you. So next steps, I know Elise mentioned this earlier. All of this work is integrated into the whole agency's strategic planning process, and it will continue to be so integrated and align with those overall planning processes for the agency. We also recognize that this is a lot of work. These priorities represent a lot, and so we're anticipating that at the timeline, probably in the vicinity of 3 to 5 years for completion. So that mostly sums it up. Again, we want to thank you for your time. We wanted you to be aware of the rebuilding work that we're doing, and also ask for your support as we rebuild and continue that preparedness, response, and recovery work to meet community needs in this changed landscape of unfortunately increasing numbers of disasters and emergencies. Thank you very much. We're happy to answer questions. We can talk about this all night.
It's been that long. It hasn't been updated.
It's been a while, yeah, and I think something that's really important to recognize is that the process of developing this plan is going to touch on a lot of our other strategic priorities. So it's going to, you know, health and racial equity connect with this work. Our sustainability, transparency, and stewardship priority connects to this piece of work. The climate action will connect to this piece of work. So we're starting to really suss out and see kind of not just where, you know, where we have strategic priorities, but how they reinforce each other and support each other to create something that's really holistic across the agency.
Yeah, I want to say I appreciate the overview, both from emergency management and also from the CDM crew. And thanks for all the work that has gone into the last couple of years. I do think this is so important for the board to continue to follow and visit, because we are going to have a lot more emergency response. And in particular, just how do we staff, how do we finance it? That is really important for the board to continue to engage in that conversation. So not tonight, but ongoing, I think is really important.
Yeah. I'd just like to say thank you to everybody involved throughout the agency. I mean, I know CDEM had a big lift here, but I also know most folks were redeployed at various points along the last 3 years, and it was incredibly stressful, often rewarding, occasionally hair pulling, but we made it, and I look forward to this evolution. I'll probably be mostly a spectator for that, but I wish you luck and success. And just again, my sincere thank you.
All right, thank you so much.
All right. Okay. We have item 6, the director's report. The comments or questions?
I know you want to dig into the details.
I think it's been a long day, so I'm sure it's just, I'll just say like a perfect director's report. I have no questions. All right. And then items old and new business. I have none. Okay. And, finally, at 7:23, we are adjourned. Thank you very much, everybody.
Excellent.
Well,
Yeah. Thank
we're
you.
almost-
everyone.
Thanks.
Thank you.
Okay.
Bye.